Okay, I'm just going to go ahead and review most of the stuff that we talked about in class, maybe just add a few things just to make sure you have understanding of these disorders of the upper gastrointestinal system. Esophageal tumors are most commonly the adenocarcinomas that are found in the distal portion of the esophagus, leading to all of these signs and symptoms that they've listed very well here. These are typically more severe in a patient with esophageal tumors. These signs and symptoms are more severe in a patient with a tumor than with somebody with like a peptic ulcer disease or a GERD, and they're more persistent, and that is what would lead the provider to suspect that there might be esophageal tumor. So they're more intense, and there's more persistent symptoms involved in this. Treatment is, depending on the site, depending on whether it has metastasized to other parts of the body. Chemo and radiation, of course, is going to be, we've talked about all the different side effects from chemo and radiation. Surgery and nutrition therapy is of most importance and consideration for a patient with esophageal tumor. These surgeries are large surgeries that are definitely going to affect a patient's nutrition. So post-op, there's going to be concerns about a patient's being able to maintain their nutrition. That can be done with TPN, which is total parenteral nutrition, and this means that they would be fed through their veins. And the reason they do that is because these patients that have these surgeries, that typically most of their stomach is removed or it's made into part of their esophagus, so they might have to remove their esophagus and then pull the stomach portion up. And so that area has to heal before they are able to take any food in. And once it does heal, they will have to eat small, frequent meals. They're not able to eat large meals because a portion of their stomach is gone. So really a big thing post-operatively is nutrition for these patients. So TPN, and then a J tube might be inserted, and that's a tube that goes into their jejunum. And they have to put it down that low because we can't do a G tube. We can't put a gastrectomy tube in. We have to do a J tube in an area that's below the area of the surgery. So maintaining their nutrition in these two different ways is important for the nurse to have an understanding of. TPN, big thing. If it has to be stopped for any reason, there's a lot of what TPN is made up of is a lot of electrolytes, sugar, there's a little bit of insulin in it. So if somebody is their TPN is abruptly stopped, the nurse needs to monitor for hypoglycemia. Their blood sugars can drop. So if for whatever reason it has to be stopped abruptly, the nurse would have to monitor the patient for signs and symptoms of hypoglycemia. Other post-op care would be an NG tube, so just be important for the nurse to be able to understand the care of an NG tube. A lot of that is checking placement, and so with a patient with a surgery like this, you're not going to be putting much in the tube. Basically, it's going to be there to do some suction to remove any kind of irritating substance in order to let the patient's stomach heal or their surgical area heal. And always post-operatively, especially immediately post-op, you're going to watch for bleeding in a patient, any signs and symptoms of any kind of a bleed. Watch the wounds, maintain the wounds, monitor for signs and symptoms of infection. And basically, a really big thing to know about esophageal tumors is be able to identify someone who is presenting with possible signs and symptoms and be able to identify it quickly, because the quicker this is identified and treated, the better off the outcome. Gastritis is simply put just inflammation of the gastric mucosa or submucosa. And it can be an acute gastritis. It can be just from exposure to an irritant. The irritant may be H. pylori. It could be just some staph, bacteria, some salmonella, just a bacteria that can just cause some irritation to the stomach. Sometimes NSAIDs can cause an acute gastritis. And basically, the stomach typically has the ability to heal itself quickly, and it's usually just a small term gastritis. It can be chronic. Chronic can be associated with H. pylori again. It can also be related to excessive alcohol intake, radiation therapy, smoking. Chronic smoking can cause, and it's just that exposure to that toxic irritant that can just cause the inflammation of the mucosa of the stomach. Signs and symptoms of acute gastritis are typically more of an obvious gastritis. It's that nausea, vomiting. They could be vomiting blood just because the submucosa can have a little bit of bleeding, heartburn, and loss of appetite. Your chronic is going to be a little bit more vague. Again, maybe some nausea, vomiting, but probably not blood in the case of chronic gastritis. Gastritis is typically diagnosed with an EGD, and that is the test that they take the scope down through the esophagus and take a peek at the stomach, and then they can actually see the status of the stomach lining. A biopsy can be taken with an EGD to determine if there is H. pylori present. And if it is present, they will treat it as such with the treatment of 2 antibiotics and a PPI. So the EGD is the best test because they can actually view the submucosa inside the stomach. And if you think about this, this is going to be more definitive to make the diagnosis as opposed to like a barium swallow. A barium swallow, they just take a picture of the structure that they can see with the x-ray. And then the EGD, they can actually go down and see the tissue within the lining of the stomach and the esophagus. So that's the difference in those tests. And that's why an EGD would be more appropriate in this situation. And just review all the prep for an EGD. You have to be in PO prior. And during the test, they do numb the throat and they sedate the patient. So post-procedure, a big part of monitoring them is to make sure that they wake up and that their airway is intact and that they have the return of their gag reflex before they have any PO intake. So other drugs that could be used to treat this is the H2 receptor antagonist, which is your famotidine, your nizatidine. Those are pretty common drugs to treat, and a proton pump inhibitor could be used also. Again, if it's H. pylori, it's going to be treated with the antibiotics and the proton pump inhibitors. All right, so if you recall, hiatal hernia is more of an anatomic problem where the lower portion of the esophagus and the stomach can kind of slide up through the diaphragm, and it can cause some irritation for the patient that are typically GERD-like symptoms. The sliding hiatal hernia is the more common, and it's where the esophagogastric junction and a portion of the fundus of the stomach slide up through the esophageal hiatus into the chest, and it's usually as a result of the weakening of the diaphragm. Symptoms of a hiatal hernia, especially the sliding hiatal hernia, are those that the patient will complain of heartburn, maybe even think they have a little bit of chest pain. Symptoms are typically worse after a meal or when the patient is laying flat. So in this case, the barium swallow is the more specialized way of diagnosing it, and that is because they swallow the barium. Remember, they have to have the ability to swallow the barium, and then they take the pictures. It's like an x-ray, and they can view the barium as it flows through the structures of the gastrointestinal system. So that is why this is more appropriate for a hiatal hernia. The barium swallow is because they can actually see the structure. They can see the area where the stomach can slide upward. Best way to help a patient with a hiatal hernia to do it managed medically is just do a lot of teaching with them. They need to sleep at night with their head elevated. That's going to decrease their symptoms. And then try to eat early in the evening. They should not eat like right before they go to bed. That's going to cause them more and more symptoms. They shouldn't wear tight, restrictive clothing around the abdomen. That'll make the pressure worse. And then obesity, if they can decrease their body weight, that's going to decrease the amount of pressure on that area and decrease their symptoms as well. Other medical management would be medications, and all those medications would be the ones that they use for the GERD as well. So it's your histamine receptor antagonists, such as ranitidine. Those are typically pretty effective for treatment of hiatal hernia. They typically do not have to have surgery unless they actually have the rolling type of hiatal hernia. All right, so moving on to peptic ulcer disease. There's 3 types of peptic ulcers. They're gastric, duodenal, and stress ulcers. Most gastric and duodenal ulcers are caused by the H. pylori infection. We talked about the H. pylori in class. It's a germ, it's a gram-negative germ that they found can be passed. It actually can be passed fecal-oral route, and it's mostly thought to be acquired in rural areas, especially those that live in an area where there's well water. The most common complication of an ulcer would be bleeding. If those ulcers perforate and bleed, they can actually cause a very large bleed that can lead to a hemorrhage if not maintained quickly. Signs and symptoms of an upper GI bleed are coffee ground emesis, or they may also have bright red emesis. Tarry stools or frank blood in the stool can be a sign and symptoms. And then if they are actually hemorrhaging, they're going to have a decreased blood pressure, an increased pulse that's going to be thready, a decreased H&H, of course, and then they're going to have dizziness and signs and symptoms of anemia if they have a large bleed. The signs and symptoms of gastric ulcers and duodenal ulcers that differ just slightly. Gastric ulcer is basically where the pain occurs is typically more near where the stomach is found in the upper left quadrant. So they typically will have pain that's sort of over to that left side of the midline, and food aggravates it. Duodenal ulcer pain is located more to the right of the epigastrum, and that's just sort of towards where the end of the stomach comes around and meets the duodenal area. And it's usually associated 90 minutes or 3 hours after eating, not right after eating, just like the gastric one is. So this is like 3 hours after they eat. All these pains may be exacerbated by certain foods: spicy food, onions, alcohol, caffeine, chocolate, and don't forget peppermint as well. Diagnosis. There actually is a serum test. It's IgG anti-H. pylori antibody that can be detected with a blood test. That is the least invasive way to detect it. The EGD is going to be the test that they go to for an invasive test for this, and that is again because that allows them to go down with the camera and actually visualize where the ulceration is, and to, if they need to treat it. That way they can also do biopsies for the H. pylori if they need to as well. So the primary focus of treatment for a patient with peptic ulcer disease is drug therapy. The drug therapy is going to provide pain relief, eliminate H. pylori if that's the cause, and heal the ulcerations, and also to prevent reoccurrence. So there's several different things that can be done. Typical management for H. pylori infection would be a PPI such as Prevacid. They would again add metronidazole, which is Flagyl, with tetracycline. A couple other antibiotics might be used, such as clarithromycin and amoxicillin. Remember, if somebody is allergic to penicillin, they're going to have to stay away from the amoxicillin and probably the clarithromycin as well. So they could go to maybe some Levaquin. That's a different antibiotic for that. So it's important to know whether a patient has allergies before you treat them with these meds. We've talked about PPIs. We've talked about H2 receptor antagonists. One thing that I want to mention is Sucralfate, which is known as Carafate as well, is a mucosal barrier fortifier. It is a protector. It's a pretty good drug in the fact that it can actually protect the lining of the stomach. And remember, the focus of treatment for a person with peptic ulcer disease is to treat the current problem, but also to prevent it from happening again. So this drug can be used, Carafate or Sucralfate can be used with perhaps an H2 receptor antagonist as a great drug regimen. So what would happen is this Carafate is used as a protector. So the patient would take this on an empty stomach about an hour before they eat and at bedtime in order to protect their stomach from the meal that they're about to take. The main side effect of Carafate is constipation. It can cause that. The other thing to be aware of is that you cannot give it along with an antacid. It needs to be taken an hour, within an hour of it. So they should not be taken at the same time as an antacid. Again, for healing and prevention of further symptoms of peptic ulcer disease, the diet is going to be important. They need to eat small meals. It's less irritating. And stay away from those foods that can cause the symptoms. They need a bland, non-irritating diet to help them avoid bedtime snacks, eat small meals, and make sure that their head is elevated at night. Avoid alcohol and tobacco as always. Okay, so just take a quick peek at appendicitis. It is an inflammation of the variform appendix that is in the right lower quadrant. It typically occurs in younger adults. The inflammation is typically caused by an obstruction of the opening of the appendix. It's located down by the ileocecal valve and the cecum of the colon. And that area can get obstructed, and then it builds up bacteria, and then it becomes inflamed, and it can cause a lot of pain. Usually signs and symptoms of abdominal pain followed by nausea and vomiting, and then look at risk factors, with their age and any family tendency. What other signs and symptoms come along with it? They typically have a loss of appetite. There's a couple of signs that can also lead to it. McBurney's point is the place that is located in the right lower quadrant, midway between the anterior iliac crest and the umbilicus. There's something called a rebound tenderness, and if you press on the patient at McBurney's point when you release, if they have increased pain with the release of that pressure on that area, that's called a rebound tenderness. That's a positive sign for appendicitis. Other signs is abdominal pain that increases with cough or movement and is relieved by bending up their knees. That would suggest that there's a perforation of that area. So a couple of signs that can help diagnose appendicitis. Patient typically has an elevated white blood cell count because it is an inflammation. The ultrasound is a way to diagnose if their appendix is enlarged. They can just do a non-invasive ultrasound to see. They'll typically put a patient with suspected appendicitis on an NPO diet until they determine whether surgery is going to be required or not. If somebody is diagnosed with appendicitis, they will typically go ahead and schedule surgery. There's a lot of very low invasive endoscopic surgeries that they can do, laparoscopic surgeries to remove the appendix. They usually go ahead and get it out of there because they don't want it to perforate, which means burst. A burst appendix can become a very complicated mess, basically, because what happens is that small appendix bursts and releases all of that bacteria within the peritoneal cavity. So basically what happens if to suspect appendicitis is somebody spikes that has suspected appendicitis, if they spike a high temp and they have increased amount of pain, then they are going to be suspected that they have perforated their appendix, and they're going to go straight to surgery. Because the complication of that is peritonitis, which we're going to talk about next. Here I just added a few of your pictures of the anatomy and physiology of actually just the anatomy of the gastrointestinal system, just for you to review. So peritonitis is an inflammation of the peritoneum, which is the cavity that contains the organs of the gastrointestinal system. So a common cause for peritonitis is when there is a burst appendix and it releases bacteria. Once that bacteria is in that cavity, it'll cause an inflammatory response that causes vascular dilation. It allows an increase in the amount of permeability, which causes a change in fluid, causes a fluid shift. It drops the blood pressure. It can lead to a septic shock. So it's a very scary situation. It can be life-threatening to have an infection in your peritoneal cavity. We're going to talk about some other disorders as far as the lower gastrointestinal system that can cause peritonitis as well. But it's just real important to understand that it is a life-threatening situation that needs to be treated promptly. Common signs and symptoms: rigid board-like abdomen, distended abdomen, nausea, vomiting, of course, diminished bowel sounds, high fever, tachycardia, dehydration, maybe possible respiratory compromise. They're definitely going to have an elevated white blood cell count. Surgery may be required in order to go in and treat whatever happened in there to cause the peritonitis, to clean it up, and the patient will be treated with antibiotics. An NG tube post-surgery is something that they're probably going to have. They need to let the bowel area heal, and they're typically not going to give them anything by mouth until that area is healed up. And that concludes the review of the upper GI system for Module 5, Nursing 150.